and more than 15 years here. The establishment, a very specialized mycetoma clinic and wards in Soba University Hospital, the MRC. We all gave lectures to fourth-year students, to final students, to doctors. We gave sessions to the Society of Surgeons, seminars. The topic were held in different medical schools. We gave guidelines. Ahmed drafted guidelines, medical management of mycetoma, and distributed now in the MRC. And we had the third international conference here in Khartoum in 2002. In spite of all this, we still find a few who prefer a pure surgical approach to treatment, exemplified in radical surgery or amputation. This is the tragedy. Or a mix-up of drugs prescribed without distinction between actinomycetoma and neomycetoma. I had 3 students from the University of Juba, and they sent a questionnaire to 700 doctors. 34% prescribed drugs without deciding whether it was actinomycotic or eumycotic. And many people think that as much as you give penicillin for tonsillitis, we will give them a prescription that will treat the mycetoma. No. The causes are so many, as you've seen in the past lecture, and the patients are not the same, and therefore the organisms are different, and therefore the response is not the same. So why is this? Is it lack of conviction? Some people do. Some of my fellow surgeons say, oh, mycetoma? Surgery, that's all. Lack of awareness by the treating doctor, or lack of awareness of the patient? Is it the long duration of treatment that puts them off? The cost of the treatment? Or maybe lack of distribution of research results? The blame on us or others? So it may be all of the above or some of them. But there is an ethical issue here. We should not be willing to dispose of patients' parts unless we exhaust all possible chances of medical treatment. And I think this is very important. Now the question of ethics and the question of professionalism is really coming up and becoming very important in the practice of medicine. So that can be controlled. We are not worried about the MRC, but we are worried about places where the doctor on his own, he might not have facilities. Instead of referring the patient, he takes them right to surgery. This is a very important ethical issue, and I think that should be in our health education. We should tell our patients and our doctors that don't resort to surgery unless you exhaust all possible. So how could we start? I mean, when I started this work, it's 52 years since Professor Gonzalez Ochoa from Mexico published his work on the treatment of mycetoma due to nocardia brasiliensis with diaminodiphenyl sulfone, dapsone, DDS. That was the only possible thing at that time, alone. In 1976, we published on the treatment of 144 cases of actinomycetoma using combination therapy of streptomycin and cotrimoxazole or streptomycin and dapsone. And this combination has a story. It didn't come as a result of the in vitro test. No, we had a patient who had secondary bacterial infection. And we sent the specimen to the lab. The result was the bacterium was sensitive to streptomycin, and he was only on cotrimoxazole. And we gave him the streptomycin for the secondary bacterial infection. And then the nursing sister said, "Doctor, this patient is doing much better than the others." She's the one who drew our attention to it. Then we went back to the in vitro sensitivity, and we found that it is true, that there is synergism. So now I think people should think of this as we get along. As new drugs are coming up, combination therapy. Well, my friend Oliverio, about that difficult case, he had 4 antibiotics at the same time till he got the result. That's multi-synergism, isn't it? What do you call that in English, Professor Goodfellow? Synergism, I thought 1 and 2, but if you have many. Yes. And this is the result. Streptomyces mycetoma, PEDs before treatment with streptomycin cotrimoxazole, and this one after treatment. And I may refer here to the criteria on which we consider there is treatment, there is successful treatment. We measure the swelling, the reduction of the swelling in the follow-up, the closure of the sinuses, but we do not stop the treatment unless we do 3 consecutive serological tests. And we had the counter-immune diffusion. Now people can use ELISA. So, and after 3 months of negative serology, then we stop the treatment. Unfortunately, we are having a bit of a problem with our serology now, but we hope we'll improve it and catch up with it, because it's a simple measure for follow-up. 1984, together with Professor Sami Juma, we reported on the first successful treatment of Mycetoma by ketoconazole, the figures that were shown by our respectable chairman. This is a patient who had Madurella mycetomatis, and he is a special patient because he is a graduate of university and he can afford the treatment, and he did very well for a complete year on ketoconazole alone. He has some surgery before, and I showed our chairman, Dr. Al-Abdullah, the final results, which I took a week ago. Very satisfactory result. This was taken during the progress of the treatment. So I still have my belief in the ketoconazole. We start with it for 2 reasons. We have no alternative. We still can get some good results with it. Oliverio Welch and his colleagues 25 years ago in 1987 reported on the use of amikacin alone and in combination with trimethoprim sulfamethoxazole in the treatment which he presented of actinomycetoma caused by Nocardia brasiliensis. We met in 1990, Professor Welch, myself, Professor Hay from UK, and Dr. Sagher from Saudi Arabia, and we tried to put a sort of a protocol. I hope that could be available and see how we progress about this. Bonifazet reported on successful treatment of actinomycetoma due to nocardia species with amoxiclav. And the saga continues, as you have seen in Professor Welch's presentation. We are on the lookout for new drugs. We are the lookout for help from our collaborating friends from abroad, like Wendy, Professor Fellow, about the response and the sensitivity of those organisms to treatment. Ahmed Fahal had a trial with itraconazole to treat patients with mycetoma caused by Madurella mycetomas, and this is now published. 211 or 210, Ahmed? 211, yes. Now you have seen, so how do you pronounce that, Oliverio? Laprix or Lacripix? I don't know. Lacroix, okay. In 26 and Lolgru et al. 206 have successfuli treated Madurella mycetoma black grains with voriconazole. And you have heard about that from Dr. Al-Abdali. It is there, but the biggest knack is the price. Terrible price. Very high price. And I think we should leave this voriconazole aside now, because it's so good with aspergillosis. And that we leave it, because there is serious case of aspergillosis, pulmonary aspergillosis, paranasal aspergillosis, and it could be life-saving there, rather than try to get it to the mycetomas. So at present, trial is going on at the Mycetoma Center in Khartoum, where patients with mycetoma due to hemaduri, pelletiria, and somalensis are being treated with amikacin cotrimoxazole. The results are impressive. Here is one of the results. This gentleman from Eastern Sudan, mycetoma of the head, and he's very happy now because the result was so good. We hope that this trial will be written up and published soon. So, in a recent electronic article on mycetoma in eMedicine, Basilio et al. Have narrated all drugs used in medical treatment of mycetoma, their dosage, mode of action, and side effects. It's worth looking up. Professor Welsh in 2007 in the same website published a comprehensive article updating treatment of both actinomycetoma and new mycetoma. Ms. Manal here, my student, is conducting an experiment to test in vitro sensitivity of Madurella mycetoma strains against fluconazole, itraconazole, ketoconazole, and voriconazole. So this obviously was done before by Wendy, as you have seen in the posters in this place. With this array of drugs, what approach or strategy should we advise for therapy or treatment of mycetoma? Yes, many drugs, patients responding differently, different organisms. What should we do? Well, I put this forward to the audience. They can modify it, I can agree with it. Site of mycetoma. Is surgery possible? Actinomycetoma or eumycetoma? Drugs different. Any previous mycetoma treatment? Try different drugs. Any previous surgery? Recurrence? What drug cost can he or she afford for sustaining treatment? And this is the problem, because we all know now that the treatment takes average of 9 months. Yes, we had ones whose pelletiria responding in 4 months, for example, but not all cases are pelletiria. For actinomycetoma, all agents of actinomycetoma start with streptomycin 1 gram per day intramuscularly plus 2 tablets of cotrimoxazole. That's what the practice was. Twice daily for 1 month. Do not disturb successful treatment. If treatment fails, shift to amikacin. If no response, shift to streptomycin dapsone. Beware toxic effects to bone marrow or anemia, leukopenia. Supplement treatment with iron and folic acid. This is what can be afforded by, and it still may give you some good results. To conclude, debulk the swelling by limited surgery. Although limited surgery, this, if you do your ultrasonography or MRI, it might not be limited surgery. Start with streptomycin, intramuscular, co-trimexazole, folic acid. Encourage the patient to drink a lot of water. If there is no response, go to B. The same as A, but replace co-trimexazole by dapsone. If no response, go to C. Amikacin, 15 milligram kilogram body weight intramuscular, total co-trimexazole, 2 tablets. If no response, go to D. You may give amoxiclav, 150 milligrams per day, folic acid. I stopped giving rifampicin for one good reason. Tuberculosis is a big problem in Sudan, and we are having tubercle bacilli of multi-drug resistance. And so we do not want to encourage the use of rifampicin in the community, fearing that we may increase this. So we stopped it. At one time, we used the anti-malarial, which are using now, the artesunate and fansidar. We also stopped that because malaria here in Sudan is a big problem. So follow up all patients by counting number of sinuses, measuring circumference of swelling, assessing hematological profile, counter immune electrophoresis for level of antibodies, plain X-ray if bones are affected. Beware ototoxicity from streptomycin or amikacin. Similarly, watch complications of anemia and leukopenia from dapsone. Thank you.
Thank you, Professor Mahjoub. Now we carry on with the experience, Dr. Fahal.
Since we met Professor Welsh in Paris some time ago, we started a trial here in Sudan on a combination of amikacin sulfate with co-trimexazole. Now we got about 160 patients in that trial, and we are giving them this combination of amikacin sulfate and the co-trimexazole. We have two problems. One problem that we have to give this patient a longer cycle number. None of the patients had responded to one cycle or 2 cycles. Some of the patients had 10 cycles. The other thing, when shall we stop the treatment? Because once you stop the treatment, the patient will go and then will come again with recurrence. We do an ultrasound in this patient, we found the grains is still there. And we do the cytology and we find in the cytology the grains are still there. Are they active? This is the problem. In some of the patients we did some cultures and we grew some of the organism there. As you know, it is difficult in our center to grow these organisms. Probably with advice from Paul, we are going to shift to brain heart media and hopefully going to have more yield in these organisms. That work should have been presented by Dr. Amal Obsaba. She is not here, but we have a good series, 160 patients almost with Mycetoma, treated only with these drugs. We're still having resistance to these drugs. Now we're shifting to other drugs, that is, we are using augmentin. You know, some of the patients where they're resistant to this. We are in that trial. who are seeing patient regularly in the clinic every 5 weeks, having audiometry measurement, they having a renal function test assessment every 5 weeks. Without having figures, we see few patients with ear problem, hearing problem, but I can't give figure because still we are working on that trial at this site. None of the patients had renal problem. We are doing renal function tests very regularly. None of them had abnormal liver function, renal function test at this site. So this is the thing that I can't give figures because still we are working on the figure at this site. Thank you very much.
Yes, I will take over, if you allow me, the part of this final session. And before I introduce the last speaker, if you allow me to congratulate Professor Sheikh and Professor Ahmed Fahal for initiating, maintaining, and sustaining this good work through the years and establishing a center of excellence in this part of the globe. Will you join me to congratulate these guys? So the last speaker for this session, Dr. Muhammad Arbab. He is an associate professor of neurosurgery. He is a consultant neurosurgeon. He got his PhD from Lund University in Sweden back as 1986, and he is a member of Swedish Board of Neurosurgery. Dr. Arbab, he will talk to us about cranial mycetoma management. The floor is yours. Thank you.
Well, thank you, Mr. Chairman. Distinguished guests, ladies and gentlemen, good afternoon. The reason I am here, when Professor Fahal asked me that there is a conference on mycetoma, I said with pleasure I would be participating in that conference, because my feeling this is the right forum where I should bring this topic. People are experts in the field from different specialties, and to bring to this floor the constraints of a clinician, I saw that is a good place where I can bring the cranial mycetoma problem. Secondly, I am very happy actually here. When I was a medical student and we came across mycetoma for the first time, I do remember in the medical faculty that it's a difficulty to find a reference from where you can take your notes. And it was only at that time I remember, that's the book of Professor Sheikh Mahayoub, one single copy probably in the library. It is very difficult to find at that time. It is still today that is we are learning from Professor Sheikh. He's telling us more about mycetoma. And I must say this work being done with collaboration of many people who are in the field. I am not seeing Professor Hassan, who is the man who used to see the specimens and tell us that is a mycetoma. Professor Fahal, with the Mycetoma Center, we used to have this cross-sort of information. So my talk is going to be about, I'm just going to going through quickly about the rationale of this study, the objectives, clinical characterization, case presentation, and then I'm going to conclude and give some recommendations. The rationale, Sudan keeps to be still the homeland of mycetoma. So there is strong justification that we should look at this problem. And still, as all speakers mentioned, there's some sort of under-recognition of the disease, both at the medical level as well as the community level. And I must say now, when we speak about cranial mycetoma, it is has aggressive behavior, which needs real attention. And I say, in the past we used to believe that mycetoma is a slowly progressive chronic problem, which is mild. But when it comes to the brain, it behaves in a sinister manner, which really calls for more attention. And finally, the inadequacy of definite cure for the problem when we speak in terms of cranial mycetoma. So in this work, the objectives were to characterize clinically the different patterns of cranial mycetoma and give a note about its pathological verification, and then finally to highlight some important features as regard cranial mycetoma. This study went on over 10 years' time, and I must say this is a personal experience. Patients whom I saw at Sharp Hospital, whom involved in the referred clinic, they came either being referred by somebody else or came for the first time. And that was the material in 10 years' time. I've been seeing some 30 patients. The age range from 4 to the youngest was 4 years, and with this mean age of 32 years. Again, males predominate. Almost 2/3 of the patients were male, the third females. The treatment option, and I will come to that later, in some 7 patients, it was chemotherapy alone. The rest of the patients underwent some form of surgical intervention. And again, I am going to explain it later why was that. Looking at the clinical presentation of this patient, we know when we speak about the classic triad of mycetoma, then when it comes to the brain, it is a bit different. Because we see that is here, at least in the number of patients we have been seeing, scalp swelling was the most, it was the most presenting symptom, followed by headache, epileptic seizures, and then discarding sinuses. So it's almost only 1/3 of patients presented because of a discarding sinus. The message here is that we should not wait for mycetoma to have a full-blown classic presentation when we come to the head. Things are a bit different. And then cranial nerve palsy is as equal as discarding sinuses. And again, that's very important. We later see that is because mainly mycetoma affects the skull, the foramina of these cranial nerves. Because of hyperostosis, hypersclerosis, then it is going to affect the cranial nerves. And then papilledema in some 9 patients. Now look at me at this lady, smoothly healthy skin. Nobody will say that is mycetoma. And the question, if you are going to see such a patient, okay, where was she when this swelling starts? When it was a really small nodule till it reached this size. Nobody could ever say she denied any history of previous trauma. There was no discarding sinus, obviously. And that is proved to be streptomyces somaliensis. Or this small boy. Just look at this head. Multiple swellings spreading all over the head. And again, you can scarcely see a discarding sinus, which again is streptomyces somaliensis. Or this unfortunate boy, multiple discarding sinuses. Now that's typical. When you see such a patient at the clinic discarding grains, you say, oh, I got the message. It must be mycetoma. But should we wait till that time? I do not like to see such a patient to present at this stage because it is really late stage. It means a lot. It is not just a question of discarding sinuses, but I will show you later how serious the problem could be. Or this girl, yesterday or the day before yesterday, we heard about the epidemiology of the disease. Well, Professor Abdurrahman is not here, Abdurrahman Tom. I just want to say this is from the Nile state. And again, she came with these scarring signs not only from the head, but as well from her cheek, and it proved to be Streptomyces somaliensis. Or this lady with the scarring signs behind the ear affecting her hearing. So we look at this, and through the investigations, ordinary investigations, that these are the results of the isolated organisms. In 20 patients, the isolated organism was Streptomyces somaliensis, followed by Mycetoma mycetomatis. And in 3 patients, one was Actinium maduri, and the other one is Piltrii. I must say about these last 3 patients, because the 3 patients actually, when they presented to the neurosurgical clinic, they were showing manifestations of increased intracranial pressure and cortical irritation. That's mainly one of them, that is the maduri, Actinium maduri. He came in status epilepticus actually. And when we did a CT scan, we thought we are dealing with a patient of meningioma. And it is only surprisingly when we opened, then we discovered it was not a meningioma. So these are the CT findings of this patient. Again, I must stress this slide because I feel in the future, when I speak about the neurosurgical perspective, most of these patients I have hyperestosis when you do a CT scan. And the combination of hyperestosis and bone erosion again in 1/3 of patients. It is interesting to see that the lesion is extra intracranial in a number of patients, followed by exclusively extra cerebral lesions in 5 patients. And this last group of patients, 7 patients, the lesion was wholly intracranial. Not only intracranial, intracerebral lesions, with no subcutaneous mass, no extracranial mass. That is what, when we speak about the bony changes, how it can aid us in the future, and I hope people will agree that is to set some sort of a protocol how to approach clinical characterization of patients who are presenting with scalp swellings in general. So you see the hyperestosis, how the hyperestosis, of course I'm not trying. You can see how this bone is thickened, and even with the skull X-ray, you can see this osteolytic changes. Or in such a patient, where you can see that the erosion of the bone at the base of the skull, almost here the bone has gone, or where you can see an extracranial lesion, subcutaneous lesion, but again with association of sclerotic bone or hyperestosis, while intracranially there is nothing here. But you can look at these patients now. This way there is an extracranial lesion as well as intracranial lesion infiltrating the bone, causing edema. You can see the edema with marked midline shift of the ventricular system. And that's what we call it alarming presentation. Such patient, it is not only of that extracranial lesion, but he has got as equal as intracranial lesion is causing really a clinical deterioration. And this sort of patient, where I'm going to raise the question at the end of my talk, how much time should we give for chemotherapy? Or you can see such massive infiltration. The whole base of the skull is distorted, and I must say this patient came with multiple cranial nerve involvement, multiple pulses. basal infiltration again. You can see how the bone is involved everywhere. The whole base of the skull is infiltrated by the tumor. Or in these patients. Now, this one, the first one is the one due to actinomyopathy. And this is mycetomatis, and this is pilitriae. While in the first patient, because of the lesion is very adjacent to the bone, I can still say, well, this is an early picture, so that you cannot probably see the bone clearly, but there is a degree of hyperestosis. But when you come to pilitriae, you can see that the bone is quite smooth. There is no hyperestosis, in spite that the lesion has caused that mark effect. MRI picture. This is of a patient. You can see basally how it is affecting the brain, close to the paranasal sinuses. And at first I thought I probably am dealing with aspergillus, because now and then we used to see invasive aspergillosis. But that was not true actually. It proved to be mycetomatis. An attempt to look at the blood vessels, and here you can see that is the bone is hyperexposed, and there is plenty of small vessels reaching the bone, and so that is the swelling here, extracranial swelling, and this is the bone you see, and now you can see the new proliferation of vessels to the bone and the lesion side. Now I come to this case, which we shared with Professor Fahal, and what I am bringing to you is a 24-year male from Western Kordofan. And his first presentation actually was in 2002. At that time, his presentation, because of drooping of the right upper eyelid, double vision, and he had a healed scar over left eyebrow, and he reported history of trauma to the left forehead. That was his picture at that time. I just want you to notice the proptosis of the right eye and the healed scar over the left eyebrow. Ptosis indicating oculomotor involvement, and at that time he was 15 years old. He went through chemotherapy, and Professor Ahmad told you about almost 5 years, Ahmad. And at one time he was regular, and then he was away. And then when he came now this year, you see that is the eye, the proptosis showed marked improvement, now back to normal. And the scar here, what is new now? The left eye is coming out. Proptosis of the left eye, and not only this scar started to discharge fluid and grains, black grains. That's when you press to the side of the scar, that's what you obtain. And you see the proptosis, how this eye is coming out. That is 9 years later after his first presentation. That is MRI. Now, just observe with me that you can see this well circumscribed lesion inside. And you can see compromising the frontal cerebral hemisphere. Not only this, you can see that it is distorting the roof of the orbit, and in actual fact it is moving towards the other side as well. and even you can see that it's affecting or destroying the paranasal sinuses.